Dylan, a 38-year-old woman diagnosed with ruptured appendix, was hospitalized for an appendectomy. She developed peritonitis and was discharged 9 days later with a left peripherally inserted central catheter line to home care for IV antibiotic therapy. You work for the home care department of the hospital. You have been assigned to Dylan's case, and this is your first home visit. You are to do a full assessment on Dylan. During the assessment, you notice a large ecchymosis area over the right upper arm. You question her about the bruise, and she tells you, "The nurses took my BP so many times it bruised."
Here are the by-part tasks that should be explained and discussed to all of you. For the question number 1, it will be answered by Mr. Susano. For the number 2, by Mr. David, to be followed by the patient's progress. Then for the number 3 questions, it will be answered by Ms. Cortel. For the number 4, Ms. Baston. Number 5 question is for Ms. Mora, with the number 4 patient's progress, followed by number 6 for Ms. Paras, and Mr. Corpus for the patient's progress. For the number 7 question, it will be answered by Ms. Asuncion, and followed by the explanation of Ms. Kiambao about the pathophysiology of medical diagnosis of the patient. And for the question number 8, it will be answered by Mr. Flores. Lastly, for the additional tasks that can help to solve Dylan's case are medical interventions. It will be discussed by Ms. Bondok. While for the nursing actions, with rationales is for Ms. Cruz, and the case outcome of Dylan is for Ms. Yambao. Hope it is all clear to all of you. Let's start assessing, discussing, and planning for Dylan's case.
First, we define what is appendicitis. Appendicitis is an inflammation of the appendix, a finger-shaped pouch that projects from your colon on the lower right side of your abdomen. It is caused by infection due to the blockage in the lining of the appendix. The bacteria multiply rapidly, causing the appendix to become inflamed, swollen, and filled with pus. If it is not treated immediately, the appendix will rupture. When the appendix bursts, the lining of the abdomen or the peritoneum will become infected with bacteria and will lead to peritonitis. Peritonitis is an inflammation of the peritoneum, usually due to bacterial and fungal infection. Ecchymosis. It is a dark purple spot forms on your skin when blood leaks out of your blood vessel into the top layer of your skin. Do you accept Dylan's explanation? Why or why not? Yes, because the patient blood pressure can only be taken on her right arm due to the placement of PICC line on her left arm. Repetitive blood pressure taken in the same area put too much pressure and can cause trauma to that area.
Question number 2. What question would you ask Dylan to elicit additional information? For question number 1. Have you noticed if it's spreading? Rational. Petechia that develop quickly over a few hours may mean that a serious infection or lack of platelets has developed and requires immediate medical treatment. Question number 2. Have you changed any household products such as laundry detergent, fabric softeners, soap, and body lotion? Rational. Detergent and softeners is a factors of having a rash, and petechia may look like a rash, so it is a way to determine if she has petechia or a rash. For the question number 3, have you been placing ice or heat to this area? Rational. Too much cold can constrict our blood vessels, and too much heat exposure widen blood vessels that can damage it. Case progress. Dylan hadn't noticed the petty before you pointed it out. The rash does not itch or cause pain. She has never had one like it before.
Number 3. What other information would you want to gather? First, have you ever had a fever? Appendicitis usually causes a fever between 37.2 and 38 degrees Celsius. You may also have the chills. If your appendix bruised, the resulting infection could cause your fever to raise. A fever greater than 38.3 degrees Celsius and an increase in heart rate may mean that the appendix has ruptured. Second, have you been taking any over-the-counter medication or laxatives? Do not take laxatives to relieve constipation. These medicines increase the chance that appendix will burst. Also, avoid taking pain relief medicines before seeing your doctor, because this medication can mask appendicitis symptoms and makes diagnosis difficult. Third, do you take aspirin after appendectomy? The incision and your abdominal muscles may ache after long periods of standing. Take pain medicine as recommended by your provider. Aspirin or other pain medicines may raise your risk for bleeding. Only take medicines that your provider has approved. Fourth, do you usually bruise easily? Easy bruising sometimes indicates a serious underlying condition, such as blood clotting problem or blood disease. Signs and symptoms of DIC may include bruising, which may appear easily, and often in various areas as well, dots or large patches. Fifth, do you have a history of blooding or clotting disorders? Coagulation disorder can result in either a hemorrhage, too little clotting that causes an increased risk of bleeding. Because the clot is blocking blood flow, it may cause blood to back up into the affected extremities. This may lead to a ruddy or red color of the skin along the small hemorrhages called petechiae. 6. Does anyone in your family have a history of bleeding or clotting disorder? It is possible that certain risk factors may contribute to the likelihood of DIC. Because DIC is characterized by severe disturbances of the coagulation cascade. Inherited abnormalities of coagulation proteins are candidate risk factors. DIC very rarely occurs spontaneously without underlying illness. 7. What color are your stools? Blood in your stools from bleeding in your intestines or stomach. Blood in your stools can appear red or as a dark and tarry color. Taking iron supplements also can cause dark and tarry stools. 8. Are you having difficulty in passing stool? Do you vomit? Inflammation of the lining of the abdominal wall or the peritoneum can also occur. This can cause pain, nausea, vomiting, and constipation. If left untreated, it can be life-threatening. It can be caused by a variety of diseases which your doctor can diagnose and treat. 9. Have you noticed any blood in stool or other body fluids? Signs and symptoms of DIC depend upon the underlying condition, such as infection, trauma, or malignancy, and on the severity and the extent of DIC. In addition to the signs and symptoms of the underlying condition, those of DIC are associated with bleeding and inappropriate clotting. Significant bleeding usually occurs from at least 3 different sites: blood in the stool or urine from internal bleeding. The wound is not discolored or draining. The abdomen is tender to palpation. There is oozing of serous and genius fluid around the PICC insertion site. The rash is confined to the trunk. You make a decision to call the physician regarding your findings. The patient's progress will be continued to be answered by the question number 4, which will explain the relying of the results for the physician.
What vital information will you relay to the physician? Always start by identifying yourself. Good morning, doctor. This is Nurse Baston calling. I am one of the nurses assigned to providing home care to our clients. I called to report my client's progress. Her name is Dylan, a 38-year-old woman diagnosed with a ruptured appendix and developed peritonitis. She is 9 days post-op and has a left peripherally inserted central catheter line for her IV antibiotics. She has petechiae confined to her trach, a large ecchymosis over her right upper arm, and a serosanguinous fluid oozing around her PICC insertion site. There is no draining or discoloration to her surgical wound. However, her abdomen is tender to light palpation. Aside from those, I am concerned about her risk for bleeding and infection. Is there anything would you like me to do since I am still at her residence?
Case progress. The physician orders blood to be drawn for coagulation studies and a complete blood count with differential. He says he would like to evaluate Dylan for DIC. For the question number 5, what laboratory tests would you expect to see performed in coagulation studies? Number 1 would be the CBC with differential. Rationale. This is to rule out anemia and platelet count. So in DIC, there is an abnormality in coagulation, so CBC will give us the background, how low the platelets and RBC. Because it is expected to patients with DIC to have low platelet and RBC count. So DIC depletes coagulation factors and consumes platelets and activates fibrinolysis. The next one would be the Factor V assay. Rationale. Factor V is a clotting factor. It is one of the most important factors that helps the blood to clot. By making this test, it will help the healthcare provider to determine the prognosis of the disease, and in the ICU, Factor V is expected to decrease due to continuous prothrombic and fibrinolytic processes. The third one would be the fibrinogen level. Rationale. It helps to find out whether we have a bleeding or blood clotting disorder. This is an important protein made by our liver. If we have a bleeding anywhere in our body, fibrinogen is released from our liver and travels to the site of bleeding to help form a blood clot. The next one would be the PTT and APTT. Rationale. Prothrombin time and activated partial thromboplastin time evaluates the time and the ability of the blood to clot. Because of the consumption of coagulation factors, PT and activated partial thromboplastin time or APTT are expected to be prolonged in cases of DIC, meaning that time and ability of the blood to clot is prolonged because of the depletion of the clotting factors. The next would be the simplate bleeding time. Rationale. This is to determine speed of the platelet formation. This also helps to identify the people who have defects in their platelet function. The last would be the D-dimer test. Rationale. D-dimer test is elevated in patients with DIC, and a positive D-dimer result may indicate the presence of abnormally high level of fibrin degradation products. It indicates that there is a significant blood clot or thrombus formation and breakdown in the body, or there is an active clotting formation in the body.
You give Dylan a dose of her antibiotic and draw her blood. You tell her that you will return in 6 hours to give her another dose of antibiotics. She asks you, "What is going on?" How would you respond? As you know, I talked to your provider about what I have found during our assessment. We are concerned that your body might not be forming blood clots like it should. The blood that I just collected will be tested for clotting factors. This will tell us if you are able to form clots normally, which are responsible for stopping bleeding. If you notice any changes such as a rash increasing in size, any blood in your stools, urine, or other bodily fluids, difficulty breathing, or feeling lightheaded or dizzy, please contact me right away. You drop the blood off at the hospital and proceed to your next visit. When you return to the car, you see that Dylan sent you a text wanting you to come back now. When you return to Dylan's home, she greets you at the door. She is upset and ushers you to the bathroom where you find blood in the toilet. She tells you that she went to the bathroom and urinated blood. A tissue she used also has blood appearing sputum and some bloody drainage from the blood draw 2 hours earlier. You call 911 immediately to have Dylan's taken to the emergency department and notify the healthcare practitioner of your actions. You call the emergency department and give your report to the RN on duty.
Number 6. What are you going to tell the triage nurse? Answer. Hello, my name is Nurse Therese. I am providing home care to Dylan. She is a 34-year-old female that was treated for a ruptured appendix 10 days ago with peritonitis. She is 9 days post-op and has a PICC line for IV antibiotics. 2 hours ago, she had PTK confined to her trunk, ecchymosis to her right arm, serosanguinous fluid oozing from her left arm PICC site, and her temperature was 99.8 Fahrenheit. All other vitals were within normal limits. Her abdomen was tender to light palpation and there was no draining or discoloration to the surgical site. At that time, I drew coagulation studies and they were dropped off at your facility. I am having her brought to your facility via ambulance due to the possibility of DIC. 2 hours post-blood draw, she is still bleeding from the site. She has also urinated blood and she has bloody sputum. Do you have any questions?
For the question number 7, are the patient's signs and symptoms consistent with DIC? Yes, because the PT, INR, PTT, split fibrin products and the dimer were prolonged. Platelets, platelet aggregation time, clot reaction time, and fibrinogen level were decreased. The WBC result of Dylan is 12,500 per millimeter, and the platelet count is 46,000 per millimeter. It means the lab results are consistent with DIC. Also, the patient is urinating blood, has blood in her sputum, is bleeding from her blood draw site from hours prior, has petechiae to her tract and ecchymosis to her right upper extremity.
Since the patient has a presenting signs and symptoms consistent with DIC or disseminated intravascular coagulation, I will now present the pathophysiology and show how the manifestations happened with patient Dylan. So for this case study, the risk factors identified are recent surgery since our patient is post-operative and had an appendectomy that later on developed into peritonitis, a condition where there is an inflammation in the peritoneum of the abdominal cavity due to the infection from a bowel or burst appendix which is present to patient Dylan. When a person is injured or there's alteration in the system such as presence of infection, our body compensate. When there's an injury, there's a clot formation to stop the bleeding with the help of proteins that control clotting factors in the blood to stop bleeding. In DIC, these proteins become abnormally active. DIC is a serious disorder wherein hemostasis that involves coagulation is out of control. A quick review of hemostasis. When there is an injury, platelets form on the injured wall or site, or what we call platelet plug formation. Then coagulation cascade takes place, wherein inactivated clotting factors, which are mostly protein, becomes activated. Then fibrinogen that turns into fibrin form a mesh to harden the clot. Fibrinolysis happens when clot breaks down, especially when your body doesn't need it anymore, and also for it not to become larger. So overall, there is a lot of clots being formed. At the same time, DIC is called consumption coagulopathy, wherein there is consumption of platelets and clotting factors that later on result into bleeding. So imagine, It is a paradoxical condition or contradicting condition. There's too much clotting and there's too little clotting. Imagine a scale. To maintain blood homeostasis, the scale should weigh the same to keep its balance. The clot formation and clot breakdown should be equal. In DIC, there is imbalance. That is why too much clotting and bleeding happens, and there are clinical manifestations seen on the patient. So how do this happen in DIC condition? With the risk factors stated, there will be a release of procoagulants like tissue factors, enzymes, and other proteins which are the precursor for coagulation. So this will increase clotting. So the scale is tipped off more on the formation of the clot. There will be a widespread clot formation that may occlude the blood vessels. And we know for a fact, once a blood vessel was occluded, there will be insufficient blood flow to the organs that it supplies, so tendency ischemia occur. With DIC, the primary organs that are affected the most are the brain, kidney, liver, and lungs. They may lead to necrosis then proceed to organ damage, a complication. And another complication that may happen is anemia. Due to the blood clots within the vessels, RBC cannot pass through easily. It becomes squeezed, which distort and break the membranes of RBC. This will result to early breakdown of RBC, the primary component that carries oxygenated blood, so it will lead to anemia. With the widespread of clot formation on the other hand, this is where bleeding takes place. How does this happen? If the injured site is already sealed off with clots, why is there still bleeding? Just like what I have said, DIC is also known as consumption coagulopathy, wherein the platelets and the clotting factors are consumed. So there will not be enough platelets and clotting factors to be used. There will be depletion in the values that can be seen in laboratory result. There is a presence of low platelet level and prolonged PTT and APTT due to the depleted clotting factors, where we know these two determines the time and ability to produce a clot. With this, bleeding may take place. This may manifest through urination with blood or hematuria or blood in the sputum. Another thing that happens that causes bleeding is plasmin activation. Plasmin is a fibrinolytic agent, and when activated, the mesh or the clot form during hemostasis break down. It will degrade and destroy the clotting factors. That is why fibrinogen level decreases, which then the clot form will be removed. That result in laboratory values for the D-dimer to increase. This value, when elevated, it means the clot breakdown is increased or elevated. This may cause bleeding. And with our patient, in our case, after 2 hours, there is an obvious bleeding on the site where blood was drawn.
The goal for Dylan is to treat her underlying condition in order to resolve her DIC. This can be accomplished by treating her peritoneal infection with broad spectrum of antibiotics. Maintaining her hemodynamic stability is also one of the priorities, which can be done by doing close monitoring, transfusions, and resuscitation for the meantime. And lastly, her skin integrity must also remain intact.
Here are the medical interventions. First, antibiotics. To treat DIC, the underlying cause must be treated. Sepsis is the leading cause of DIC, and the patient had peritonitis after her appendix ruptured. Second, bleeding reduction. By doing this, it will help to sustain the life of the patient. Fluid resuscitation to replace volume lost and to sustain blood pressure. Blood product admin. Packed red blood cells will improve oxygen delivery by increasing the hemoglobin content of the blood. Fresh, frozen plasma replaces many clotting factors. Platelet transfusions are necessary when they drop below 100,000 per millimeter. And for the shock management, as the patient's circulating blood level drops, She is at risk of hypovolemic shock. O2, IV, and close monitoring are the basic interventions that will save the patient's life.
These are the 6 nursing actions and their rationales. Number 1. Place the patient on oxygen. Because she is at risk for impaired gas exchange, the patient is actively bleeding, which has increased her risk for hypovolemic shock. There are not enough red blood cells to carry oxygen to organs and tissues. Number 2. Monitor BP. Assess for signs and symptoms of hypotension, dizziness, pallor, and cup refill of greater than 3 seconds. These signs and symptoms could all point to lack of peripheral perfusion. The risk of gangrene and compartment syndrome is increased in patients with DIC. Number 3. Give IV fluids. Fluid resuscitation is necessary since the patient is actively bleeding. Replacing volume loss will prevent organ shutdown. Number 4. Give the patient blood transfusion as ordered. These will increase her platelet and RBC count, allowing for better perfusion. Number 5. Give antibiotics as ordered. With DIC, you must treat the underlying cause. Sepsis is the most common cause of DIC. The patient has an infection in her abdominal cavity due to ruptured appendix. Prevent further bleeding. For the last one, give the patient the call light and have her ask for help. Move any objects that can cause injury to the patient. Rotate sites where the patient's blood pressure is being assessed and use a manual cuff until her clotting factors have improved. Use PICC line for access. Do not create any more trauma to the patient's skin, and rotate the patient every 2 hours. Other important actions include monitoring labs, monitoring blood loss, monitoring intake and output, and administration of heparin.
For the case study outcome, Dylan is stabilized with oxygen, fluids, blood products, and medication therapy is initiated. She is transferred to the intensive care unit in guarded condition.